Now you see, that was also a fracture of the ankle joint, and this is also a fracture of the ankle joint. But what is this is more severe though. Compared to that, this is the more severe fracture. So what has happened here? Mike Johan issue. Someday we will have to speak in such a way that the mics are open and then we all can talk. We all because you see the beauty of learning is when we all can talk and take part. Here we are. So what has happened here though? Not only there is a fracture you can see, but also that the joint has gone out of place. What is that known as dislocation? Dislocation. So when in it's a tibio-talar joint, and the talus is here, and the talus is and the tibia is here though. It's all gone out of the place, out the place. And how do you when somebody like your Professor Karam Shah is on the phone and you are talking to, so how will you describe this? Has it gone medial, lateral, posterior? That is what he wants to know though. So it depends where the talus has gone. So the talus has gone laterally. Then you have to do a lateral view to see whether it has gone anteriorly or posteriorly. So it is a lateral. There's a fracture, lateral dislocation of the ankle joint, and there's a fracture of the fibula. And what else has happened here? As we saw in our normal ankle, there's always some tibiofibular overlap. Here, the tibiofibulae are markedly apart, markedly apart. So what is this known as? This is diastasis. Why? Because the syndesmotic joint is opened up. So the syndesmotic joint is opened up. The fibula has been fractured, and the tibia and talus you can see are far apart. So there's a fracture dislocation of the ankle joint. So this has to be managed well. So he has managed well. What he has done? He has done a plate here, a long plate, and he has fixed this, and then he has put this screw from tibia, from fibula to tibia. This is known as syndesmotic screw. What is the purpose of that? He has brought this joint together because it is a syndesmotic joint, a fibrous joint, and very important. So what he has done is, so because when we walk, there is some movement at the fibula joint. So I mean naturally all looks good though, but I mean this he hasn't given a complete picture because he will put then some more screws here and here, but all he has tried to show is that he has maintained the length and rotation of fibula has been maintained, that talus and tibia relationship has been maintained, the syndesmotic joint here has been maintained. So the three aims have been achieved. The fracture has been reduced, the tibio-talar relationship has been maintained, and the tibiofibular joint has been reduced. So the key has been reduced. And nothing is complete except unless we have done a lateral view. We must see all on the lateral view. Now you might ask me, भाई इन सब के lateral views कहाँ हैं? मैंने कहा यार फिर lecture हो जाएगा बड़ा लंबा. Now what is this again? This is just to show you one lateral view. About the bikes and but what does this show? We just see. You see that yaar ye severe injury here, about it. You just see and wait, this is a severe injury though. Wait, this is the talus. This is the tibia. So this is sitting completely outside. This is dislocation, and this is a fracture of the lateral malleus. This is a fracture of the medial malleus. So what has happened here? It is a fracture dislocation of the ankle. So it is quite a serious injury. Now, although this X-ray has been done, but by law, if a patient comes like this clinically, then you have to try under sedation to reduce it first. You should go to the X-ray after it has been reduced, because if you leave it for too long, X-ray may take half an hour, 1 hour. That is too late. Why? Because if you just see here, अगर इसको आप बहुत देर तक छोड़ दे, if you leave it for too long, what will happen? This medial malleus, it is doing what? Pressing against the skin at all time. The pressure again bruise the skin. If you leave it for too long, it will pressurize the skin. The pressure on the skin is too much. So these cases must be done urgently. the pressure of the skin is too much. And if there is gross dislocation, there is an abnormality or a kinking of the neurovascular structure. So you want the neurovascular, because we're not treating the bone alone, you have to treat the whole tissue. So the neurovascular tissues have to be maintained. The neurovascular tissue will be maintained when the bone comes in line. So when this is a gross deformity, you try in the gas to reduce it, and then put a back slap, and then do an X-ray. A definite treatment will be required. But when you see a grossly dislocated ankle, pressurizing the skin, you have to reduce that, maintain the reduction in a back slab, and then have an X-ray, and then keep it elevated. And the key is, when you have a fractured ankle, when you have reduced it and put a back slab, what is the key? The key is elevation. And elevation is not that you go, nurse isko zara upar kar dena. Here also we just tell the nurse, nothing happens. Nurse ko apne kaam hai, wo pani pila rahi, kisi ko kya karna hai, kisi ko kya. They've got so many jobs to do. You take 4 pillows and put it under it. Under the ankle. Because what will happen after this severe trauma? The ankle will begin to swell up. And the best window to operate is within the first few hours, maybe within the first 1 day. If you don't operate on this within the first day, then the ankle becomes sore enough. Then you have to leave it for 2 to 4 days till the swelling goes down. But the only way to keep the swelling down from the patient comes in, as soon as you have reduced it and backslab it, put it up on 3 or 4 pillows, and then the next day you can fix it. Unless you have got the a facility to fix it there and then within 1 or 2 hours. But naturally, it depends. When did the patient come in? He might come at 2 o'clock in the night. So if you are on call, what do? You just reduce. And when you reduce it, and before, what is important? You must check the dorsal piece pulses. Make sure that pulses are right. Make sure he's moving his toes all right, though. So those are the key things. And as we discussed, in any trauma of a high energy type like this one, make sure all his other body is all right. It is not an ankle. The ankle is a part of body. You must listen to the whole body as such. But treating the human being, not ankle joint of so and so or Mr. Warsaw. It is the patient has to be treated as a whole. You can't just focus on that. So this we have discussed again. This dislocation must be reduced. Now, where is this? Is it? So Shah Sahab might ask you, but Baba dislocation kahan se aaye? Anterior, posterior, medial, lateral mein. The talus has gone where? Posterior. So it's a posterior dislocation. The dislocation is defined by where the distal part has gone. The distal part is gone. So it's a fracture, dislocation of the ankle, and the talus has gone. Here we are now. This is tibia now. Now we have come down tibia. In a motorbike accident, I mean in Tibia, just as you know, in Pakistan, I also worked there for about 10 or 12 years. And these fractures, they are common. And when do they come? They're especially common in motorbike. And they run motorbike and the young children. And when are these young children going too fast? You sit on a motorbike and they're going with full speed. When is that? In Ramadan time, when there's aftar. They will go to this Sogashin, take the samosa and jalebi on the scooter, and their hands, and they're speeding drive. Then you get many of these community tibial fractures during that. And of course, then road traffic accident. And then in many people, if you're not driving, I mean, too well, then you can hit the people on the road. But what has happened? It is, you see, 1, 2, 3, 4. This is what is fracture. This is a community fracture. And what is this? Of the fuel as well. But you don't need to treat this. You treat this and you maintain this by a intramedullary rod, or is known as nail. I am intramedullary nailing, and this has to be fixed with the screws. Locking. Only when you put these locking screws, you will provide that stability. You don't try to touch this. This will heal itself, because there's a very important structure going around at this age. What is that? Do not disturb. What is common pudendal nerve? Common, so you don't need to do anything to this. common peroneal nerve surrounds here, and that can cause you very seriously. So just leave it. So this is. What is this then? Now, you see, that was also tibia. This is tibia as well, though. But what is this? This is a fracture of the tibia at the lower end. It is a juxta-articular fracture at the level of the articular joint line. And this is, so when there is fracture of the fibula, now the fracture of the fibula, we normally fix it first, though, because it then maintains the length. And you know where, how much the tibia is, the length, the rotation, all that. And then this tibia, it is intra-articular. All the pieces of the joint is gone. As we discussed, by definition, all intra-articular fractures must be reduced and fixed. Because the intra-articular fracture, you have to reduce very well so that they become congruent, so that the alignment is maintained. If the intra-articular fracture, if you fix it in varus or in valgus, produce abnormal strain on the joint. So the alignment has to be absolutely straight. Number two, intra-articular fracture, you don't want a step into the joint. If there's a step into the joint, the distribution of the load is not correct. Therefore, it would be important to just fix it. अब आप लोग final year में हैं तो you don't know how to एक भाई कैसे fix करना है, plate कहाँ लगानी, but important is the length or alignment और उसकी articular surface को maintain करना है to give you the best possible result. What is this now? अब आप कहेंगे भाई हम आपसे कैसे बात करें? So this is basically, as you can see, this is a fracture of the proximal tibia. So this is a tibial plateau fracture. This is a tibial plateau fracture which has been which is not only on one side but on both sides, 1 and 2. So it's a bicondyle fracture, and then there are all these pieces, and there's all depression. So it's a very complex and very complicated injury. Again, when you see an injury of this type, tibial plateau fracture which is meshed up, examine the patient. Make sure there's no abdominal or a chest or head injury. Because in all road traffic accidents, more than 50% cause of the death is because of the chest injury. Make sure there's no associated chest trauma to that. So it is very important that you examine the patient as a whole. In all acute injuries, severe, high energy severe injuries, this is a high energy injury. You can see the mesh, this is a bone mesh. Now this has to be treated very well. So when you see this, what goes through the mind? A, exclude any other body trauma, and B, you must make sure the neurovascular structure is okay. Neurovascular structure is okay. And C, then you have to maintain it in line. Now, when he comes in, what will be the first thing? Then he will be got to swollen. He's got a got to swollen leg. The patient is not very well. He's got a bad trauma. He might have a chest trauma. So you have to just stabilize it. Stabilize. So you can put an external fixator. Fixator 2 pins, I mean, you would put pins, 3 pins in the femur, 3 pins in the tibia, and keep it, straight. That is, what is that known as? It's known as spanning. Spanning. Spanning means to span the fracture and stabilize it. After spanning, what do you have to do? You have to do a scanning. Because these are fractures, many people will do a CT scan. CT scan will show you, because those are the cuts at 2 millimeter or 5 millimeter level. It will show you where are the large chunks of the bone and how much is this bone depressed. How much do we need to bring this bone up? Because you have to form again a tibial plateau. What is the tibial plateau? It's a part of joint though. It's part of the knee joint. So it's intra-articular. You bring it up again and make that form. So this tibial plateau. So we have to do a span first, span, and then scan. So once you've done the spanning, what will the spanning do? Spanning will provide stability to the bone. And remember the key sentence is stability to the bone provides stability to the soft tissue. The soft tissues will only begin to heal when there's a stable bone. So stability to the bone provides stability to the soft tissues. Only then it will heal. So you are giving them a fixator so that the swelling will go down. It will become stable. Soft tissue will begin to heal. You will check for the neurovascular structure, and then you will plan. we must have a plan in our life. We must have a plan in our everyday life. You see, Allah who has created us, He wants us to be good in those things which is best at, most merciful. He wants us to be most merciful. He's most kind. He wants us to be kind. He forgives the most. He wants us to do that and keep our hearts clean. Similarly, Allah says, Wallahu khairul makirin, Allah is the best planner. He wants us to plan, fracture planning, life planning. Every day our life should be planned so that we use our time and the opportunity in the best possible way. You have to plan your life. So we have to. So what is this treatment here is span, scan, and plan, and then this can be fixed in many ways. The standard way nowadays, in this case, would be to fix the elixir of external fixator. Why? Because you pass the pins and you don't damage. Because in our key thing we said, what we have to do, respect the soft tissue. If you take out the too many soft tissues and bring the bone line, what will happen? Avascular necrosis. You might end up in having. So we have to maintain the soft tissue respect, and you have to also then treat it in the best possible way. But there are more than one ways. Some people who are good at plating, they might make 2 incisions and put 2 plates on. Some people who are good in fixators, they might put a elixir of circular ring fixator. That might work here though, yes, very well. But you as a final year student, when you see these patients, what do you have to do? Put them, examine them neurovascularly, put them into the back slab, make a general examination that there are no other bodily injury, the neurovascular structure is okay, and keep them. And the back slab has to go from the thigh up to the ankle joint, keep elevated. And he needs to go to theater so that we can put at least a fixator in the initial stages till we have a definite plan of putting either elixir off or a fixation. Depends upon what expertise there is. Some people will do this though. This is a plating on both sides and it works well in some cases. Some people will do this. This is a elixir off external fixator. So it's a different way of treating, but both are depends upon which center you are, what expertise you have. But the key is that Hippocrates oath, we must not damage. If we know what to do, we should do it. If we don't know, we should send it to the one where it can be done in the best possible way. Behind all this fracture is a normal living human being who's got a life, and so you have to care of a man as a whole. Now, what is this then? This patient who has come in, again, is high velocity trauma. What is going through your mind? What has happened to him? Right. Well, I know that you all are thinking, well, it's very obvious. He has some nasty injury to his knee. And let us go and do his x-ray. Oh my God, what's happened here? He's dislocated his knee. Dislocation of the knee is a very serious injury. Very serious. And which dislocation this is? Is it anterior? Is it posterior, medial, lateral? The medial lateral you can only know when you are done an APU. But on the lateral you can know is it posterior or anterior. Now where is the distal part, the tibia? From here. So on this what you see is a posterior dislocation of. Now when you see these patients in the casualty under the entonox with gentle drink, try if you can reduce. If it doesn't come with very gentle, then you must take them to the theater, and this is urgent cases. Why? When the tibia has gone back, it is pressing. It is pressing against what? Pressing against the popliteal artery. So in these cases, there is always a risk of pressing on the popliteal vessels, and also the risk of pressing on the posterior tibial nerve and the peroneal nerve. So if there is a vascular injury, there's also a 40% incidence of having a associated peroneal nerve. Now this dislocation, it is a very serious, because A, it has to be reduced well, and B, with this dislocation, what else damage has been done here though? 3 out of the 4 ligaments which are maintaining the knee, they are torn apart. At least in some there are 4. But if not 4, at least 3 of the main ligaments supporting this are torn apart. What are those? Anterior cruciate ligament, posterior cruciate ligament, and then on the side, what are on the sides though? Collateral, medial collateral ligament and lateral collateral. Collateral means side. Co, साथ lateral side. So side के साथ collateral ligament. Cruciate because they cross each other. The one which is anterior cruciate, one is posterior. That the posterior cruciate ligaments, anterior cruciate, and the side, the 4 ligaments, there's a known. That is a very important thing that keeps the knee intact. You must have been torn though. So this is quite a severe trauma. Must be a bad road traffic accident. The knee is dislocated. So you have to reduce it back. And when he has come, you must check the dorsal species pulse. Dorsal species pulse has to be checked. And posterior tibial pulse has to be checked. The neurovascular examination has to be done. Can you move? Can you move your toes? Quickly, can you feel the sensation? So when you see these patients, naturally, if it is dislocated under the internox, don't force it though. You don't want to break it. You don't want to cause more harm. Attempt very gentle. If you can't, take him to the theater. It's emergency. And under X-ray control, you must reduce it well. Reduce it well, and then once you reduce, again check if there is any loss of pulsation, or the foot is white, or the foot is not really pink, or then you must involve the vascular surgeon. Because just as you know that if there's a damage to the popliteal vessels, then we need to repair them in a short time. That is known as warm ischemia time. Warm ischemia time. What is a warm ischemia time? Warm ischemia time is how much can a limb survive without its main blood supply at a room temperature. If you freeze the body, it might live longer time. When you transport hands or fingers, put them in ice so that they can survive a bit longer. But in a room temperature, how much can a limb, the muscle survive at a room temperature? How much is that? Is it 2 hours, 6 hours, 1 day, 2 days? It is 6 hours. 6 hours is the ischemia time. So it's a good enough time. I mean, if you can have access to the vascular team, they can come. So it is very important to the vascular assessment. And as you said, dislocate knee, sort this out. And then in the theater, put a long back slab so that back slab and also on the side. And then this can be treated by a multi-ligament knee specialist. There was various theories. There was a theory of putting it into the knee cast for maybe 6 weeks, 3 months, but now many people try to fix those ligaments at an earlier stage. Otherwise, if we keep it in plaster for too long, there has been a bleeding, all will become what? It will become fibrosis, scarred. That known as arthrofibrosis. It can become a very stiff joint, very stiff. What is this then? Now we have come from the knee to the femur. Now the femur fractures are quite common. There can be a fracture of the lower end, supracondylar, fracture of the shaft, or a fracture of the neck. Now, naturally, when you come to the orthopedic department, now in this country, fracture of the neck of the femur is the most common. We have at least 1 or 2 every day. So we have about 300 to 500 fracture neck of femurs every year. So we have to just fix them, or we have to do a hemi or arthroplasty in them. In Pakistan, luckily, fracture neck of femur is not that common. I mean, it is common, but not very common. But here you have got, even in a small hospital, you get 1 or 2 cases every day. Anyway, so here we are. The fracture femur again, as we were discussing, fracture shaft of the femur is again a high energy trauma, because femur is the strongest bone in the whole body. The femur is the strongest bone in the body. It can bear the compression force a lot, but femur is weakened, torsion. Agar aap uska gala bori, the torsion forces, rotational forces, femur can break. But otherwise, compression force, you jump on it, the basketball, netball, volleyball, jumping at it, but over time, your normal body weight is, say, 100 kilograms. When you're walking, you are putting 400 kilograms through the femur. When you're running, 1600 kilograms. When you're jumping and running fast, 6400. 6400 kilograms of weight you're putting through this femur by jumping and by running and basketball. But femur doesn't break. But if you rotate it, पाँव आ गया कहीं पर आपका, फंस गया पाँव और आप, body has rotated. The same femur with much lesser force will just break. Now, in the shaft of the femur, the best treatment usually is intramedullary nailing. Intramedullary nailing, because it is mechanically more stable. Mechanically more stable, and people can start to the. It is not a load bearing; it's a load sharing device. Load sharing device. So you have to just keep an eye, and then people will walk on walk on crutches and will start to put weight on it. As soon as you see there's more healing in all these, whether you're putting external fixator or you are doing this, what's the key? The bone contact. The more there's a bone contact, the more to at the side of the structure, there should be a good bone contact. You see this? Ye yahan par bone, ye yahan par bone. So the healing will not be very good. But here you are, there's a good bone contact. The more better the bone contact, the more better the healing is. Now we come to the key. You must say, because when I was speaking to Shah Sahab was saying that I start with this first. I mean, he's absolutely right. Why? Because this is a very important, there's no doubt about that. Because this is life and death. This is because you want the head. This is head. Everybody wants his head, but we want the femur head as well to survive. The head is the rule. So you don't want the patient's head to be lost. But actually, you have to understand here that the fracture of the neck of the femur, I mean, Shasa will tell you how common it is there. But when I work there, you see them common, but not. But here it is very common. The reason is that this elderly age group, 65 of the people here are over the age of 65. You normally operate here. There, one is 90, 92, 101, 102. This is the patient. When you go on the list, DHS 91, Hemis and 98 for this. So in this age group, and people are living in the care homes. Many elderly people, they just live on their own. They're 95, they're living on their own. They just do all the jobs. 89, living on their own, doing their washing, cooking, cleaning, dressing, all the sorts of. Many people who are very ill, they will have some carers though, but 89, 19, 95, and when they go out, because their bones become weaker, they become osteoporotic, and then they have a fall, they can have a fracture of the neck of the femur. So fracture of the neck of the femur is very common here. Why it is so important? Because they have this key, that this is an artery, external iliac artery, femoral artery, and it gives a branch here, lateral circumflex and medial, which are supplying the head. So the neck of the femur fracture is important because there's a blood supply going there, and if it is broken and displaced, it might rupture the blood supply, and there's a risk of getting avascular necrosis. So why is this important? Why is this so important? So a 90-year-old lady, 89-year-old lady. So what is the matter? If the neck is broken, you throw the neck and put a new neck in. That's known as hemiarthroplasty. Because normally it's a ball and socket joint. If you don't replace the socket, just replace the ball, it's hemiarthroplasty. Arthroplasty means new joint. But in this case, we're not giving a new joint. The exhibit is the same. In a new head, so it becomes a hemiarthroplasty. Saying, what is the problem? The head is broken, you take it to the theater and you put a new head in, the story is over. What problem is when this happens in a young man, 60-year-old. You might say 60 is young, but 60 is a baby. 60, 65, 70, we just treat them just as small babies. 40-year-old, because this can happen in a 40-year-old having a road traffic accident. It can happen in a 40-year-old lady having a horse riding. What do you do then? You want to save it though. You want to save it. It should be treated as an emergency. We used to treat it as emergency, as if the patient comes in, you have to fix it straight away though. But nowadays, it is best to fix it on the immediate next available list. If it comes in the morning, you can do it in the afternoon. But if it comes late night, then best not to do late night, but do first thing in the morning. So if there is fracture neck of femur, the treatment is, very simple. Very simple. There are certain guidelines. Guidelines. What are the guidelines? The guidelines is if you have a fractured femur which is displaced in an 80-year-old, 90-year-old is displaced. If it is already displaced grade 3 and grade 4, the risk of avascular necrosis is high though. No need to save them in a 90-year-old lady. You will take the head out and put a new head in. That is known as hemiarthroplasty. And she walks the next day. She can fully weight bear. Doesn't have to be cautious. How can you tell a 90-year-old lady कि भाई वजन मत डालो या थोड़ा वजन डालो? You can't. And many of these 85 and 90-year-old lady are not composed mentis. उनको समझाना कि भाई partial weight bearing not possible. You cannot tell her how to partially weight. How can she? She just can't. But if it, similarly, but if it happens in a 70-year-old lady, if it is displaced, then what do? Then you see how good she is though. If she's a 70-year-old lady who is fit and well, who is walking, then rather than giving her a hemiarthroplasty or half hip, you can give her a total hip. Luxury treatment, a total hip replacement in her case. A total hip replacement in her case. So if there's a, so what determines whether it's a hemi or a total hip in a 70-year-old lady or 80-year-old, what determines that? What was her pre-fall mobility status? If her mobility status, if she was walking outdoors, 70 साल की औरत है भाई वो बस में जा रही है अपना ट्रैवलिंग के शाम वो अपना शॉपिंग वॉपिंग कर रही है, she is going out, she is outdoor community worker, she needs a total hip. If there's a displaced fracture neck of femur in a lady who was active and mobile outwards, total. Displaced neck of femur but not walking outside, hemiarthroplasty. अगर undisplaced है और patient समझदार है, then you can put screws or a DHS to hold it. Then you have to save the head. If the lady who is 60 years of age or less than 60 years of age, then you will always discuss with them, get as bad reduction as you can and try to fix it with either screws or with a DHS, dynamic to hold it. You want to save the head. However, if you must understand, if it is a displaced fracture neck of femur, even in a young patient of 60 or 40, there's a risk, always a risk of avascular. Displaced है, आपने इसको reduce तो कर दिया, fix भी आपने कर दिया. You want to save the head, but there is a 30% chance it may go into avascular necrosis. तो मरीज के साथ discuss करें. You will talk to the patient. कि भाई, shall we do this one operation of hemi or shall we do this 2 operations? But because you're very young, you're 40 or you're 50 or 60. 60 here is also got is very young. We call them babies. 60-year-old baby. To ask them. Many of them will say, yes, doctor, I want to take a risk. I want to save my head. We all want to save our head. But anyway, so they will say, we want to save the head. So we will put screws in it and try to save it. 1/3 in 25 or 30, the head may fall down, go into avascular necrosis. Then you can get out and give them or a total hip. In a 60 active lady, you fix the head falls down. What do? You give them a total hip. So this is a very important. So, and the other thing that you have to know here is the fact intracapsular or intracapsular or extra. Between this greater trochanter and lesser trochanter, there's a line goes here, which is the trochanteric bridge, where the capsule is attached. Anything which is inside the capsule is inter. So all we are talking about fracture neck up till now was intracapsular. Above the fracture, उससे बाहर. If it is in the trochanteric line, then it becomes extracapsular. Extracapsular, the treatment is all the same, 40-year-old or 90-year-old. What do? You fix them. That's it. Because in extracapsular, there is no risk of any vascularity to the head itself. So the fracture neck ki jaan, the take-home message, which Shah must have told you, is only 2 things. Is this fracture intracapsular or extracapsular? If it is extracapsular, going from the trochanter here downward, capsule, ये जो capsule के attachment से नीचे अगर है, capsule के attachment, extracapsular, तो भाई treatment is only one. You have to fix it with the pin and plate or with a DHS screw or dynamic hip screw, or sometimes people even put a short nail in. That's fine. That's fine. So there's no argument extracapsular fracture in all ages. You have to fix it because there's no risk or no concern about the vascularity. Intracapsular, which is just below the head or into the neck or just below the neck, it has been divided subcapital, transcervical, or basal. Basal, sometimes people will fix it with the DHS though. But अगर subcapital है transcervical है, अगर वो displaced बहुत ज़्यादा displaced, not in contact, and there's a greater risk to developing avascular necrosis. Displaced in an elderly, hemiarthroplasty. Displaced in a young, you will try to reduce and fix. If it is undisplaced, you will try to fix it. You can either fix it with screws or you can fix it with the DHS. Screw से fixation के advantages ये हैं. I mean, you can take the screws out later on. मगर you have to have a compost mentis because screw में you have not to allow the people to put weight. So they have to be very careful. अगर कोई 60 साल का sensible lady, you can tell them कि चलो weight bear नहीं करना है, तो screws will hold fine. You don't know कि यार कब ये कि क्या डॉक्टर ने कहा चलते रहो भाई, तो फिर put a DHS. But in a DHS, sometimes we have to put a derotation screw so that holds the neck well. So the idea is to save that neck, save the head. So in a intracapsular fracture in young age, the idea is to save. But if it is grossly displaced, in Pakistan, it may be a bit more difficult. Even if she's 60, she has got a displaced fracture. It may be more difficult to save that. Why? Many people come very late though. Time is of essence. अब उसका फ्रैक्चर डिस्प्लेस्ड है, वो आए हफ्ते के बाद, अब आपको क्या करना है? Now the risk of avascular necrosis in that lady is going to be high though. So then in that case you may have to, if 60-year-old, 65, हाँ अगर 40 साल का है और वो आया है, then sometimes people might use some bone graft or something to people may try their level best attempt to save the head in a young. Young doesn't mean 21. Anything below 60 is young. I'm looking at 60 or young man. ये क्या है? And then this is another common problem. कि भाई patient comes to you, had a fall, has got a hip pain, groin pain, actually looks normal. क्या करें भाई, इसको घर भेज दिया? क्या करें भाई, normal है. Then the ideal test to do in a fracture like a femur, if the X-ray is normal, is to do an MR scan. मगर MR scan can take a longer time. फिर हमारे पास MR 2 मशीनें हैं, लेकिन वो टाइम उनको मिलता है हफ्ते के बाद. बताएं जरा, how can you wait? वो तो कैजुअलिटी में आया तो आप उसी वक्त, तो we can do the CT scan within 10 minutes. उसको CT scan करा दिया. अब ये बिजनेस का भाई, the X-ray, CT scan में there was a doubt, but still not very clear. MRI करा दिया, तो here you can see there is fracture. MRI. And then we put a DHS. DHS has been done. This is a young lady of 60, displaced. The fracture was displaced. We reduced it well and put with screws. Magar 6 months down the line, the fracture has collapsed और screws के बाद. अब the fracture collapsed हो गया और screw बाहर. तो screws के ऐसे बात करें तो कहाँ जाएंगे screw? Acetabulum already eroding the acetabulum. अब अगर आप इसको निकाल के इसका हेमी कर भी दें, they will still have pain. Why? Because the socket has been eroded. इसमें क्या करेंगे भैया? What will be the treatment here? We will have to take the screw out and give them a total hip because it has already eroded the head. But in this case, 90% or maybe 70% will work very well too. Many of us, if they're young or if they're 40 or 50, they will like to take a chance. Doctor, I would like to take it to save the head. So as you can see, what is this? This is an intracapsular fracture. What is this? This is a extracapsular fracture going through the trochanter. That's a trochanter again. Extracapsular. What have you done? This is a DHS. Another extracapsular DHS. What is this we have done? This is intercapsular, and you have done a hemiarthroplasty. You have put a ball and here. socket is patient's own. Then there's a young. Young means 65 or even an 80-year-old who is 80-year-old can be young though. My next door neighbor, he's 80 years, he walks 5 miles a day though. He's very good, he's a happy man. So if he has a displaced intercalateral fracture, displaced, what we do, we'll give him a total hip. We'll give him a total hip. He might be 60 or might be 80. But the fact that determines is his general health good? Can he withstand an operation? And what is his mobility status? If he's able to walk around and go around and do everything, then of course I'm minimum. अब शाह साहब कह रहे होंगे यार तुम्हारी बातें तो बड़ी करते तुमने तो बता दिया 10 अब 20 ये तुम क्या हो रहा है तुमको यार अभी बस बात भाई फिर वो pelvis के ऊपर if we come then just to let you know that this is on each topic from ankle to the pelvis we can speak hours and hours now. There's no end. You know, just we're looking at these x-rays, then management, then the CT scans, then the MRI, then the treatment. But the basic thing important to know is what you have to know is that fracture, when you see, treat the patient as a whole. Make sure that the patient is all right. When you are called to the casualty, there's an open fracture of his tibia, and you rush around and start dressing the wound and think about his tibia and his x-rays. Think about the man or the lady. Think about the patient. Is he alive? Has he got any chest trauma? Has he got anything else? Exclude, examine the patient as a whole, do the ATLS protocol, and then come to a limb. If that is the only injury, then come to that limb. If it's open wound, he needs antibiotics. He needs the tetanus cover. He needs the wound washout. He needs the back slap, support. Don't ever transport the patient without supporting him. It causes tremendous pain. When the bone moves, there's tremendous pain. In the plaster, when you put the plate on, or when you put even a plaster back slap, the pain is gone. The bone hasn't healed, but it stopped moving. It's the movement that causes pain. It's cruel to keep moving the patient from the trolley to the exit without any support. The pain is tremendous. So support them and be nice to them and give them the painkillers. Above all, before we become doctors, we have to be humans. We have to feel their pain and share their pain. And the least thing we can do is to look at them with a smile and hold their hands and say, you'll be fine. You'll be fine. Then we come down, and then these pelvis fractures, they can be just fixed in this way, and then there's a lot more going on. But I think it is now already 11:28. We've only touched the tip of the iceberg. Next week, we're going to talk about infections of the bone. I'm very grateful to you all, but I'm very grateful to Karam Shah sahab. He's very kind. He has given me this chance to come and talk to you, and I feel very happy. And inshallah, I will be greatly honored to talk to you again next week. If there are any questions, there's only just one minute left. That is very naughty. When you're talking, you must leave at least 10 minutes, but here I'm a very naughty man. But next time, I will try to keep the talk to about 40 to 45 minutes so that you have at least 10-15 minutes to just talk about it. Okay? So it is now getting time. 1 hour is gone. वो शाह साहब हमें छा ख्याल आया था शाह साहब और शाह साहब का माइक नहीं माइक से कहाँ जो माइक शाह साहब जी मैं शाह साहब का माइक जरा आप अनम्यूट कर
जी सर आवाज
आवाज आपकी बेहतरीन आ रही है हमेशा बेहतरीन
बस सर इंशाल्लाह कमेंगे अभी तो स्टूडेंट्स माशाल्लाह बेहतरीन नॉलेज लिया होगा कांसेप्ट लिया होगा इंशाल्लाह
ये भाई बच्चे हमारे बच्चे तो बच्चों से बात कर तो वैसे आदमी को अच्छा लगता है बहुत इंशाल्लाह ठीक है तो फिर नेक्स्ट वीक सेम टाइम इंशाल्लाह बोन इन्फेक्शंस के ऊपर वी विल टॉक अबाउट ठीक है इंशाल्लाह ओके